For those of you who've joined us, welcome to Health as a Civil Right, the Sankofa Collaborative's three-part virtual panel series. Today, we are presenting the third and final session called Community Responses to Racial Health Disparities. A few housekeeping notes. Just if you can, please keep your microphone on mute. That will help us avoid any interference or feedback for our speakers. There will be time for questions and answers at the end of the program. You can post your questions by clicking on the chat icon. And if perhaps your question relates to a specific speaker, just let us know that so we know where to direct your question. The program is being recorded, and in another few days, it will be posted on our website, and we'll be circulating it through our email marketing. And that's pretty much what we've got for housekeeping. Also, we do have upcoming programs. April 29th, there will be an almost full day virtual workshop on memorializing African-American history, cemeteries, monuments, and markers. And on June 1st, there will be a program commemorating the 100th anniversary of the Tulsa Massacre. So keep tabs on our upcoming programs page. And I'm hoping that if you're here, you're already a member of our mailing list and you'll be seeing notices with details soon. I would like to introduce Linda Epps. Dr. Linda J. Caldwell Epps is president and CEO of 1804 Consultants, and she is a founding member of the Sankofa Collaborative. She has more than 45 years of experience working with educational and cultural institutions, including the New Jersey Historical Society, the New Jersey Network Television and Radio, and she held a number of positions at Bloomfield College, where she worked for 27 years. And that is also where I got to meet Linda, actually about that many years ago. And I have long considered that to be, the lasting gift that Bloomfield College gave to me. Through 1804 Consultants, which she founded in 2011, she works with history and cultural institutions in New Jersey and nationally, including the Smithsonian National Museum of African American History and Culture, the William Trent House, the Newark Public Library, the Scotch Plains Public Library, Old First Church of Elizabeth, New Jersey, and the Timbuktu Historical Site. So welcome, Linda, and I'll turn it over to you.
She's muted still.
Good afternoon once again. And as Michelle said, I'm one of the founding members of the Sankofa Collaborative. And I would like to welcome those of you who might be attending their first Sankofa program. Welcome. And a welcome back to those of you who have been regular and not so regular attendees. We were founded in 2017. 5 New Jersey organizations, 1804 Consultants, Grounds for Sculpture, the New Jersey Historical Society, the Stoutsburg Sauerland African American Museum, and the William Trent House Museum formed the Sankofa Collaborative. Its purpose to help individuals in schools, museums, libraries, historic houses, present, interpret, and discuss African American history and culture. Sankofa is a word from the Twi language of Ghana, which translates into go back and get it. It is often depicted by a bird, as you can see, with its body facing forward and its head turned back, holding an egg. This and other Sankofa symbols remind us of the importance of learning from the past. So hence, since 2017, we presented programs and workshops with the generous support of the New Jersey Council for the Humanities, the New Jersey Historical Commission, and of course, you, our public. And I would like to give a special thanks to the RWJ Foundation and to Patient First, who also offered support for today's program. Those of you who were with us last week and the week before might remember that I started my remarks with this quote from Martin Luther King Jr. in his address to the Medical Committee for Human Rights of the American Medical Association in 1966. And he said, quote, "Of all the inequalities that exist, the injustice in healthcare is the most shocking and the most inhuman," end of quote. I mention it again as a reminder of the interconnectedness of good health and the world that surrounds us. It is no coincidence that people of color dominate those who have succumbed to COVID-19, while their infant mortality rate is higher, and why the attendance in schools of children of color is poor, lack of good health care. In 1965, just a week before also passing the Voting Rights Act, Congress passed the amendment to the Social Security Act that authorized Medicare and Medicaid. The law's effects on segregation were immediately felt. Since Medicare's universal coverage of elderly people brought federal funds to about every hospital in America, it also bound them by Title VI's non-discrimination clauses, which essentially ended segregation in those hospitals. Some of the last public arenas in which Jim Crow legally held sway. And those of us who have been lifelong residents of New Jersey, please know that we were not exempt from having hospitals within our borders that were segregated. Medicare was the final federal legal blow for de facto segregation, and without it, there would still be few legal mechanisms to force hospitals to integrate. It's hard to overstate how much Medicare and Medicaid themselves did to end formal segregation and to improve the health status of poor people. The passage of Medicare and Medicaid in 1965 helped deliver some portion of that agenda. But as with every other civil rights victory, the backlash was strong. The NAACP and other organizations would encounter resistance to both the prospect of universal health care and to the use of existing systems to end health disparities that utilize the full muscle of white supremacy. Today, we will gratefully and gladly hear from experts in the field who have struggled for years to provide the best healthcare possible for their patients, and often under difficult conditions. I'd like to add again that major funding for the Health as a Civil Right panel series came from the Robert Wood Johnson Foundation, and additional funding was provided by Patient First. And the views expressed here do not necessarily reflect the views of the foundation or of Patient First. So I'm going to introduce Shawn Torres-Anderson, who will serve as our moderator for this afternoon. Reverend Anderson is Associate Minister at Bethany Baptist Church in Newark, New Jersey, where he serves in the church's health ministry, who focuses on health issues that greatly impact the healthy life of the African American community, including heart disease, diabetes, cancer, HIV/AIDS, and mental illnesses. His role in the church's health ministry is as public health navigator, organizing COVID-19 testing events in conjunction with education and awareness sessions for the church and for the local community. For the past 8 years, Reverend Torres-Anderson has been working in public health and AIDS service organizations, including Palmetto AIDS, Life Support Services, Gay Men's Health Crises, and the Latino Commission on AIDS. Reverend Torres-Anderson studied at Union Theological Seminary, concentrating on pastoral ministry and practical theology, focusing on the intersection of spirituality and sexuality. He graduated with a Master of Divinity degrees in 2017 and is currently studying for the Doctorate of Ministry at Union Theological Seminary. This is his first time with the Sankofa Collaborative, and we welcome him. We're so thankful that he was able to join us today. So off to you, Reverend Torres-Anderson.
Thank you so much, Dr. Epps, for your warm welcome and the introduction. And we welcome all of you to this particular panel as we're talking about health as a civil right. And as we know, the health of Black and Brown folks, particularly in this country, have been impacted by a variety of things as racism and sexism and misogyny, homophobia and transphobia, and a lot of other isms that impact good health outcomes for Black and Brown bodies. And, you know, as a point of personal privilege, I've been working in the healthcare field, as Dr. Epps said, for the last 8 years, particularly focusing around folks who are living with HIV and impacted by AIDS as well, but also thinking about what does it look like to improve health outcomes, not as it relates to HIV and AIDS, but for the whole person. And for those of you who know this term, social determinants of health, it talks about the places where you live, work, play, and worship has the opportunity to determine your health outcomes. But not only social determinants of health, when we're thinking about Black and Brown folks navigating the healthcare system, we're also thinking about the ways in which extensive barriers are placed in front of them, and then the number of discriminatory practices that exist. And Dr. Epps just talked about it. I read a report just recently that was released by Duke University that says Black women with master's and doctorate degrees, their children are more likely to die than their white counterparts who have high school diplomas and GEDs, right? So we're not talking about something that just impacts Black women. We're thinking about things that impact, and Black men, we're thinking about things that impact our children as well. And the last thing I'll share before I'll introduce our panelists for today is with the entrance of COVID-19, we see the ways in which Black and Brown bodies have been disproportionately impacted by this disease. As a person who is, you know, younger and who can access the internet very well, I'm thinking about the ways in which the number of barriers and red tape that was put in front of me from getting my COVID vaccine. My first appointment was scheduled for the 14th of the 11th of February, but I got an email the Sunday prior while in church saying that there were no more vaccines in my area. So I had to reschedule. And trying to reschedule, the red tape started building up. So I had to eventually schedule for a month later and drive an hour and a half from East Orange, New Jersey to South Jersey to the mega site to receive my first and my second vaccine dose. And if I'm thinking about, you know, Black and Brown poor folks who don't have access to transportation, who don't have access, who could not have traveled the hour and a half that I have. I'm thinking about, you know, the number of barriers that not only exist when we're thinking about COVID-19, but the barriers that exist when we're talking about navigating the healthcare system as a whole. So I'm grateful that our panelists, who are experts in their field, they cover a large range of topic areas, right? So I'm grateful to welcome Dr. Edwina Verner, Bishop Dr. Phillip Bonaparte, and Miss Aliana Broach, who will come and share their experiences. So what our time together looks like is I'll introduce them one by one. They would then give us about 15 minutes of discussion. We'll engage in conversation as we ask them questions, and then we'll move on to the next person. And then at the end, we'll have a question and answer session where we'll ask questions to all of our panelists and interweaving, you know, personal experiences as well as years of experience in the field to the questions that we have. But our first panelist for today is Dr. Edwina Verner, who is a board certified in pediatrics. She currently serves and practices at the Newark Community Health Center in East Orange, New Jersey. That's where I live, and previously served as the center's medical director and director of pediatrics. She has also served as a preceptor for nurse practitioner students at Rutgers University. Dr. Verner graduated from Tufts University in School of Medicine in 1977 and completed her training in pediatrics at Children's Hospital Medical Center in DC. She also holds a Master's of Public Health from Columbia University in New York. She has been doing this work for over 40 years, and it is in her blood, as I've learned that both her father and grandfather were both doctors, and she'll share more about her story. So help me welcome Dr. Edwina Verner. You're muted, Dr. Verner.
Okay. Now you can hear me? Okay, great. Thank you so much for having me, neighbor. I am a product of some extraordinary examples of communities to health disparities. My concern and my exposure goes back to Mississippi. I was born in Mount Bayou, Mississippi, which some of you who are historians may know is a very historic town in Mississippi that was founded by freed slaves. It was founded by the slaves of Joseph Davis and Jefferson Davis, the president of the Confederacy. At the end of the war, his slaves were freed. They were actually given some land, which is where I was born, Mount Bayou, Mississippi. It's an all-Black town, continues to be a very historic place. In addition to having its own schools, its own bank, its own mills, eventually had its own hospitals, which is an extraordinary example of how to deal with health disparities. My grandfather was one of the people who realized that if we're going to have these other services, as you've mentioned previously, you have to have health service. It's a basic right. And what he did, he was the president, not the founder, but the president of a fraternal organization called the Knights and Daughters of Tabor. They were very politically active, as were many other people in Mount Bayou, and decided that we need to have a hospital in Mount Bayou. They were politically active. They went around the state, the country. He met actually with presidents and eventually got the funding to found a hospital. In addition to the political aspect of it, he went around to members of the community in Mount Bayou and said, we need to have this hospital. We are going to need to have your financial backing of this hospital. And was able to do that, founded the hospital, Taborian Hospital, where I was born. And if you speak to any African-American who is from my generation and ask where they were born, they will tell you Taborian Hospital, because that was the only place where you could go to be born. My dad, they got their medical support from Meharry Medical College, which, as many of you may know, is predominantly African-American medical school, one of the few Howard and Meharry now in the country. My dad was a resident at the hospital. One of the things that they did, their rotations were at Taborian Hospital. So he came to Mount Bayou, Mississippi to do his surgical residency at the hospital. And that's in fact where he met my mom. So again, I think this is an extraordinary example of the lengths that people who we are descended from went to combat racial disparities in healthcare. In addition, my father, who worked in Newark for probably at least 50 years. And by the way, was also a minister, a lay minister. So I'm so pleased to see that we have healthcare workers who are also ministers. It's a wonderful thing. And as you have said, they really work together hand in hand and provide us an opportunity to combat these health disparities. Towards the end of his career, he founded something called Interfaith Health Services. And what we did, because I worked with him also, he went to hospitals, he spoke to CEOs. I would go with him, talking about how we needed to do community outreach to find people who needed services, and we needed the funding to do that. So we had backing of hospitals, for example, like Columbus Hospital, which is no longer existent, but they helped us provide the services. We would actually go to churches, and at the end of their services, we would do health screenings. We did blood pressure screenings, we did weight, we did cholesterol screenings, so that, again, this is another, I think, exemplary example of how we in our own community can combat the health disparities. I work with what's called Federally Qualified Health Center, which is a program that was begun in the late 1980s, 1990, again, as a means of combating health disparities. These health centers receive federal funding and have requirements to actually function in communities of need, rural communities, urban communities. So these healthcare centers are in these communities. Our mission is to not only provide services to members of underserved communities, but also to employ members of those communities. We do outreach, of course, in those communities. One of the things at the health center where I work, which I think was very forward thinking, is we serve a lot of immigrants. We have, of course, a sliding fee scale, so you pay what you can afford to pay. And for initial visits, there is no charge. So we are able to see immigrants who have no health insurance. As I said, we employ people from the community. So the health center where I work, very visionary people realized that we were going to have an influx of Haitian immigrants to the area where I am, and employed a number of healthcare workers, not only physicians, but support staff, people who do our registration, our nurses from the Haitian community who are Creole speaking, so that we could appropriately serve people in our own community. So the other things that we try and do in FQHCs, we have their course guidelines because we receive federal funds. Our board of directors is to have members of the community on the board. The board is supposed to use our facilities so that they're aware of the type of services that we provide. We, of course, are measured by certain benchmarks. We look at things where we know there are disparities. For example, when our pregnant women begin their health care, our pregnancy outcomes. We look at immunization rates, how well we do controlling hypertension, diabetes, obesity, of course. As we know, these are all significant risk factors. And you mentioned the problems with COVID. Many of the adverse outcomes we see with COVID are because already we have in our communities these high levels of these comorbidities: obesity, hypertension, cardiac disease, lack of access to appropriate care. So the FQHC, our mission is to try and combat those disparities. I see one of our panelists is a doula. That is also, it's an old concept, but a new concept to us. So it's wonderful that we are using those kinds of concepts to look at more innovative ways that we can work within our community. One of the things that COVID has demonstrated is there is still very much a distrust of the healthcare community or establishment, perhaps is a better term, that has resulted in our reluctance to get vaccines. And not only that, the access to the vaccines. One of the things I thought was interesting, as you mentioned, since you live in East Orange, we give COVID vaccines at the health center where I work. What we have found is that because of the difficulty in making appointments for the vaccines, we were giving vaccines to people not in our community. It, in fact, was shocking that the nurses would say, look at these people, they're coming from West Caldwell, from Milburn, and other areas, because many of these, they have more computer access, more computer savvy. They're signing up to get these vaccines, and they're filling up all, and we can't turn them away. We can't say, no, we won't give you the vaccines, because we do have them, and they actually are filling up all of the spaces for the vaccines that we had, to the point where we were trying to think of innovative ways around this, which we really couldn't, because once you signed up for one, you automatically get signed up for the second vaccine. And we had a lot of difficulty. We've improved since the onset, but it was shocking to see that our own community was not getting the vaccine, and people from outside of our community had no qualms about coming into our community and getting the vaccine. So I think that we do have to be more forward thinking in how we approach these kinds of problems, how we can reach our communities better, how we can relate better to our communities. We need to, of course, be advocates for those who are not able to advocate for themselves. I tell my parents all the time, because I'm a pediatrician, I'm speaking to the parents, you have to be an advocate. You have to insist on what you know is right. If you don't speak English well, you have to ask for a translator. If you don't understand what a medical provider is saying to you, you have to say, I don't understand that. Can you tell me that in a way that I understand? So we have to educate each other that we have to be advocates for ourselves. The other thing that you brought up, and I'm not sure where I am time-wise, is that the disparities that we see go across income levels. They go across levels of education. They have their roots actually going back to slavery, and how people are perceived, how your complaints are perceived, and even people who are well educated and think that they won't be treated a certain way. You have to realize that, no, you have to advocate for yourself. Again, ask questions, what you don't understand, keep persisting until you can understand. And if you're not comfortable, then you seek additional support, additional advice, and there should be no penalty for doing that. I don't know where I am time-wise. I don't have a question. Am I done with my time?
You have about 4 minutes, Dr.
Okay.
Verner.
And so I think all of the health disparities, which COVID has really highlighted, the ongoing tremendous difference in African-American, how ill we become after we're exposed to disease, how we are treated when we go in with complaints, and that these things are as pertinent as they were back when Martin Luther King made that announcement. I don't know when it was exactly, 1960s or whatever. So this is an ongoing issue. They're deep-seated multifactorial problems, which you mentioned already. And we have to continue. It's a work in progress. Thank you. Thank you.
Thank you so much, Dr. Verner, for not only giving us a history lesson of Mound Bayou, Mississippi, but also for laying out the work that you do here in the great state of New Jersey. I do have one question for you to answer now, and then we'll move to the other questions that I have during our question and answer session. So you talked a lot about Mound Bayou, Mississippi, and the Turabian hospital in which you were born. And we know that one way to improve, our health outcomes is connected to preserving our history. Now, how do we preserve our history? How do you foresee us preserving our history that can speak to greater health outcomes for us?
Well, we still, in fact, we just had a Zoom meeting recently for residents of Mound Bayou. And that's one of the things that we talked about. We have a wonderful history, and people did wonderful things there. And of course, a lot of healthcare, as you know, is related to politics. And and you have to be politically active. Some of the things that we were very successful with in Mount Bayou, because there was political influence to the contrary, we were not, because the hospital eventually did close. Of course, the practice of medicine has changed, but you must become politically active. You must involve as many people as you can. We have, my cousin, as a matter of fact, has a Friends of Mount Bayou site on Facebook. So we have to be able to, first of all, know what our history is, know that these things are possible. And if people could do these things a few years out of slavery, I don't think that we have any excuse for not being more politically active. We should be on hospital boards. We should be speaking with CEOs. As I said, my grandfather, by the way, who was not a doctor, he empowered himself and was empowered by his ancestors who were slaves, that he would speak to a president of the United States, because this is what I need. And as we all know, improving healthcare is not just about African Americans. There's a tremendous cost in not providing adequate healthcare for underserved. The cost does not go away when you have to hospitalize somebody because they had a stroke, because their hypertension was uncontrolled. We all pay for that. There's going to be higher a cost through our insurers. Those of us who have jobs, our rates are going to go up. The hospital costs are going to go up. It behooves all of us to be involved in reducing racial disparities. We should know what our history is. We should know if our ancestors could do this out of slavery, we can do this. We have to be advocates for ourselves. We must be politically active. We can't say, well, we're doctors, we don't have to do this, or we're ministers. Of course, I mean, the history of the African-American church is, we know what that's about. They have always been politically out in front and our forerunners. So I think there's a lot that we can do. We do need to know our history. We do not need to be afraid that we cannot do this. We can do this.
Thank you so much. And for those of us, Nancy shared that it's so true, the healthcare is so political. So for those of us who do not know the history of Taborian Hospital, I encourage you to look up that information. Fannie Lou Hamer was a patient often at that particular hospital. So thank you so much, Dr. Verner. And we look forward to conversating with you, or conversing with you in a little while. Our next panelist is the Bishop Dr. Phillip Bonaparte, who is a practicing physician and senior pastor of New Hope Church of God, which has 3 locations in Central Jersey. Dr. Bonaparte hosts 2 radio broadcasts and a monthly television program in the public interest, and deals with health issues in the African American community. Dr. Bonaparte began his dual calling to the church and medicine as a young man on the Caribbean island of Grenada. He received his medical degree from St. George's University School of Medicine in 1986, and has been doing a lot of work and received a number of awards, to include the Humanitarian Award from the Red Cross, and a Leadership Award from the Caribbean Medical Mission. Help me welcome the Bishop, Dr. Phillip Bonaparte.
Thank you so much, and it's indeed a privilege and honor for me to be here. I thank the outstanding work that you do as an organization. I believe, and it's real clear, it's my passion to really ensure that everyone has equal access, and not just access, but access to quality healthcare. Of course, and was stated early on, just to kind of put it in simpler terms, or to just kind of drill down a bit, the Civil Rights Act of 1964, Title VI, made it very clear that any hospital or any institution that is receiving federal funding or funding from the government shall not discriminate, in terms of providing healthcare based on, race, color, and what have you. But we see that not overtly, but subtly, exists even today, as was stated before. Just to give a little bit of background, my passion has really been in serving the underserved population. And I've been involved in Medicaid and Medicare, especially Medicaid, for many, many years, served in various inner city hospitals, Jersey City Medical Center. I also did some work at St. Michael's in Newark, but Jersey City Medical Center in Jersey City, New Jersey, where I did my residency in the late 80s and early 90s. And I've had the privilege to provide care to people in different continents. I've done a lot of medical missions. So I've had the privilege to see healthcare delivery system in other countries. Part of my medical training and clinical clerkship was in the United Kingdom, and saw what it was like there in a completely nationalized system known as the NHS, how they provide care to their residents, and coming back to the United States and seeing how that works in our system was quite amazing to me. And so when you look at where we are today, certainly let me just say without any hesitation that yes, healthcare is a civil right. I mean, it should be an access to healthcare, good quality healthcare, ought to be for everyone. I think it just makes common sense. It's the right thing to do. It's the more cost-effective thing to do. If you don't do it early, you will have to do it and pay much more in the back end. I serve, and in terms of exactly what I do, also I work in the city of Trenton. One of the churches I pastor is in the city of Trenton, and I serve also as chairman of the Children's Future Board. And the main goal is to ensure that families, are able to develop, and just create a safe environment for children, providing healthy children. In addition to that, I do about 8 years ago now, I retired, resigned really, and retired from, working in corporate America, and also, doing that type of medicine, where now I do a free health center for the past 6 years in the city of Trenton, where 100% of the care we provide is free. So people have access. They come to a health center and get comprehensive care from about age 13 all the way up to the grave. And literally, and the current, I serve as the chief medical director for the vaccination program for the city of Trenton, just assisting Trentonians and people in the surrounding areas to have access to COVID-19 vaccine. So that was just a little bit of, addition to the background of what I do. I've also worked in corporate America, like I stated before, and worked with Blue Cross Blue Shield, Horizon Blue Cross Blue Shield, and worked primarily in the Medicaid line of business. I see one of my former boss is on, Karen Clark, who I know chaired one of the programs a few weeks ago. Here is what I note and I believe is important for us. There is no two ways about it. The studies and upon studies and years after years, this year will make it 57 years since the Civil Rights Act was passed and Title VI was clear that there should be no discrimination as far as healthcare. The outcomes speak to a different result. So the evidence point to the fact that we are being discriminated against, be it personal bias, be it institutional bias, be it access to health insurance, having access to, I would say, appropriate hospitals. We see today in many of our inner cities where quite a good percentage of our African American, members or people live, that you've seen several hospitals who've pulled out. And so you have hospital deserts where you could have just, if you're in an emergency, it would take you 2 or 3 minutes. You can even walk to the hospital. Now it will take you maybe 10, 15 minutes and you require a car. And so often you had to call the ambulance, and that's just certainly increased the cost. I believe that we can get to where we need to go. As was stated before, COVID-19, especially last year, has shown that we are impacted disproportionately to other communities, especially to our, Caucasian, brothers and sisters. When COVID-19 came out, I'm talking now from my own personal experience, I found it was almost impossible to even get, to allow and to get some of my patients into hospitals to be tested or into facilities to be tested for COVID-19. And even when I was able to get some folks to get in front of people who had access to testing, they did not receive the test. And so here's the scenarios that I've seen. There were no question in my mind, people who were exposed to someone who died from COVID-19, who had symptoms, but not quote unquote, the classic symptoms that CDC came out with early on, which is high fever or fever, cough, and shortness of breath. They didn't have those, but they were literally sick with COVID. And some who were seen in the emergency room with some of these symptoms that were sent home. One patient of mine who literally died at home. And of course, she's of African descent, and it's for the same reason. And here is a challenge, because we present differently. And so when we present differently and not knowing much about COVID, even though I'm trying, I'm writing, I'm making phone calls, speaking to doctors in the hospitals, we were not given the light of day, I would say, so to speak, and they were sent home because they looked fine. One of the things we've learned of COVID-19, I'm using that as an example, is that COVID-19 defied all of a good number of our training. Let me give you a classic example. We know it affects and impacts the lungs. One of the things we have available to us is called a pulse oximeter. And if you put the pulse oximeter on a patient's finger who comes in with quote unquote suspect or suspicion of COVID-19, you can get a saturation level. And I know the docs were using and healthcare professionals were using this as an example to determine who stays and who goes. What I've also noted, and I'm talking about as recent as about 3 weeks ago, that someone speaking, look fine, saturation level is in the 90s, which is good, will drop to the 40s within a matter of milliseconds, seconds, and will crash, requiring to be intubated. And I'm talking about as recent as about 2.5 weeks ago. The point I'm making is simple, is that because when we give our symptoms or when we speak of a problem, folks don't take us seriously or chump it up as, that doesn't add up. It doesn't make sense. It defies the logic in which we're trained in. And so as a result, in terms of pain, when you look at outcome as it relates to mortality among women in childbearing age, among African American, we're 3 times that of the general infant mortality rate and mortality from women in who are given in childbirth, twice as high, 3 times as high. That should not be in America, one of the most wealthiest nation of the world today. So I talked about things such as access. There's institutional bias there. There's differences as far as in terms of treatment. We're treated not equally the same. There are studies that were done that showed that people of color did not get the same pain medication as their white or Caucasian counterpart, for the main reason that they believe that our skin is thicker, we're able to tolerate pain at a much higher level than those whose skin tend to be thinner. Simple as that. Amazing bias. And we're talking about educated professionals, even in healthcare. And so we've seen a lot of differences there. And so there is interpersonal bias and how some folks are brought up. And especially now, we know for a fact that there is a significant rise in white nationalism in this country. And as that rise, you can only imagine what is being shared with their children, what's being shared in certain communities. It is not good and it's pretty much going backwards compared to where we ought to be as it relates to civil rights in this nation. So the government, I believe, has a role, to play. And the challenge with the laws of the past is that there's been difficulties, not difficulty, there has not been equal resources placed in ensuring that these laws are literally carried out. And so, for example, who is policing healthcare facilities to ensure that everyone has equal access, regardless of race, religion, or national or country of origin? And so, when you look at these, factors, without having enforcement, institutions know that they can get away with it. They've gotten away with it for many years, and that continues even today. What I believe ought to be done is that just as how we ensure that laws that are on the books are carried out, folks break the law, we go after them. I believe that we need to figure out a way in which there's equal, I would say, enforcement in the healthcare arena as well. You have big corporations, you have big hospital institutions, and almost every hospital in the state of New Jersey today, are connected. Very few individual hospitals that you see out there, they're attached to a big conglomerate, and they're looking at, of course, everyone needs to look at the bottom line, but too often we find that our city and communities are void of institutions that provide good quality healthcare. So, when you look at some of the things that caused COVID-19 to have such a negative impact on us, one, I talked about bias as it relates to folks believing the symptoms of people of color. The second thing we note is that pre-existing condition. We know that if you have hypertension, obesity, and or diabetes, if you have lung problems or any other medical problems, you're at higher risk of having a bad outcome from COVID-19. The African American community, the rate of hypertension, the rate of obesity is significant in our communities, and also the rate of diabetes. What that did is that it put us in the hospital and also put us in terms of mortality at a much higher mortality rate, even today. And another area that, of course, we've seen the numbers speak for themselves as far as vaccination. We ought to do a better job in getting shots in the arms in people of color who are the greatest risk. It seems to be an inverse relationship. And everything should be done in our communities to ensure that people of color receive not just equal access, but I will say even a greater access. But it required, the government just cannot say, well, vaccines are available, you go get it, when there is, like was stated before, bureaucracy with, getting online. I know educated people who got online and are waiting their turn could not get access until they had or have someone inside who's able to make the connection, reach out to the, to the folks and provide that way, walk people through. And then, of course, we know experience that we've had with vaccines and programs, of course, of the past, and the trust of people of color with the healthcare, institutions is not great. I believe my time is up. I want to stick to that, so I'm going to pause. I wanted to say a lot more, but I'm going to pause here at this moment and turn back to you.
Thank you so much, Dr. Bonaparte, for that wealth of information. I love how, Dr. Verner talked about FQHCs, and then you're talking about hospital access, along with a lot of other things. And I do have, there are questions that are coming in for the both of you, and I'm sure questions will come in for Ms. Elena as well. But for Dr. Bonaparte, one question for you right now, and then we'll ask the rest for later. And if you can answer this in about 30 seconds. You talked a lot about hospital access, and we know that hospital access looks different in the North than it does in the South. We know 47 hospitals have closed or have filed for bankruptcy last year in rural areas, more of them located in rural areas. And one of the problems we saw were people were using the hospitals as primary care facilities. And the American Heart Association, in conversation with them sometime last year, said that we've overcorrected the problem. Right now, people are not accessing the hospitals as largely as they were when we were trying to correct this problem. What recommendations do you have for folks who are, teetering between going to a hospital or going to a doctor's care? Like, what recommendations do you have for gauging, where they may be and then deciding which route to go?
Sure, that's an excellent point. Well, we have more reliable now urgent care centers across New Jersey, and I think that is a great place. Let me give a classic example. One of my daughters, they were skating, she fell and came home late, one night with a swollen hand and wrist, predominantly wrist. And I, took a look at it and looked at it and said, this doesn't look good, wiggle your fingers. She couldn't really do much of it. I said, I'm pretty sure it's broken. But rather than send her to an emergency room, we found an urgent center that closed. We did the research, find out if they had x-ray. Really all I needed was an x-ray, and that would tell me exactly what we need to do. So she had an x-ray, was able to, determine that there was a fracture and was a bad one. And when I looked at the report, I said, I'm pretty sure she would need surgery. So we got her an orthopedist. So she didn't need to go to the hospital at all. The cost saving to her, because of course the copay for her health insurance, and then in addition to the institution and to a society, has been reduced significantly. But this requires education. And we need to do a better job in getting, I would say, not just public service, announcements out, but educating the population on how to and use examples. The key, people will relate to examples. And I think in terms of having that availability, COVID makes it a little different. And I know you said 30 seconds, so I'm going to stop.
Thank you so much for that and adding that copay piece in, right? Because my copay for my hospital visit is $200, but for a doctor's care is about $40. So thank you for adding that. So thank you so much, Dr. Verner and Dr. Bonaparte. And now we are on Elena Broach. And Dr. Verner alluded to her earlier that she's a doula. So Miss Elena Snell Broach is a 20-year maternal health practitioner and trainer as a labor and postpartum doula and a certified professional midwife. She cares for pregnant families and delivers babies within African traditional teachings in the homes of families in New Jersey. Ms. Snell-Broach holds a license as a social worker for counseling and policy, administration and planning from Rutgers University, New Brunswick Advanced Standings Program. I'm really excited about, the entire conversation, but talking about this, because as Dr. Verner alluded to earlier, this is an old and new concept, right? If we're thinking about, my grandfather was born in his home in South Carolina, Sumter, South Carolina, but now folks are moving towards, having more at-home childbirths. So help me welcome to the stage Miss Elena Snell-Broach as she comes with her presentation.
Okay, so greetings everyone. I'm trying to share my screen. If I cannot, are you able to do that, please?
Yes, I'll go ahead and get that done.
Elena, this is Sam. I just made you co-host. You should be able to share your screen now.
It's okay. If you could do, thank you. So just to say a little bit about my introduction too, I apologize because I did not see it, but I myself am also a minister. And it's significant and important to say that because the office of being a midwife is a spiritual office, and I'm kind of challenging you all. And for some of you historically who are from the South, such as myself as well, in my family lineage, we already know that the concept or the understanding of a midwife historically is significant in the delivering of majority of the American nation. Okay, but you can go on to the next slide. So just letting you know, this is one of the prayers that we usually say or we do in the beginning of our meetings and any of our openings. But again, just speaking to that office of where we come from. So myself, my family originated from Georgia, specifically in a place called Snellville, which we were enslaved and we were upon the plantation and such. And then there was an uprising that occurred. They call this, it was a battle between the white Snells and the enslaved Snells and such. There was a divide in the town. So similar to what you were saying, Dr. Edwards, is that you had a Black portion of Snellville and so forth, a white portion. So in understanding this, a lot of my traditions of growing up, I'm from a lineage of healers, a lineage of reverends and pastors and such, and strong proponents of the bringing up of the Black church up here in the North, in Newark. So in what was passed to me as far as being a midwife and being a doula, which I will share the difference between the two, because as you were saying, a lot of you know more commonly now what a doula is, but you're not aware that there's a difference between the doula and myself, who is also now a midwife. So in how I should say, in coming into this, understanding that midwives spiritually, you could go to the next slide. Midwives spiritually were in the office biblically, and God really had a high esteem for us. And why? Because in our roles, before enslaved even, traditionally we're known as healers. We're the actual spiritual leaders of the community. We are the ones not only who did birthing, we also were in charge of deaths. We were in charge of blessings. We were in charge of marriages. We were also in charge of bringing people together, but blessings, like I said, also baptisms and so forth. So it's a very high office, whereas it's, downplayed throughout the years to be more of a mundane role. But in actuality, the calling specifically of the Aboriginal midwife, the Black midwife, comes a lot with a lot of spiritual connotations. And for many of you all, as well as healers and doctors in your families, is the same way. You can go to the next slide. So this is just an example of us, Shifra and Pua, very strong in Exodus results, or just, as seeing as the midwives and how the edict was given, to kill all of the male children. And these midwives were like in such a fear of God and knowing and saying that, that's not something that they were going to do. But so much too, in like today's time, there's a standard, there's an edict that's happening, whether it is an unseen, as we can term it as institutional racism, white supremacy, these racial disparities, the attack that's happening on our Black families and Black women and babies. I want to highlight today, though, instead of looking at it from the sense, which is usually historically how it is, we get blamed as Black or brown bodies that we're not educated enough, or that we don't know, or it's just our misunderstanding, and we've had to be taught, where instead of, as you're saying, the research is showing it is our system that is broken. You can go to the next slide. The difference I want to say between modern time of the midwife and the doula. So a doula is a trained professional who's from the community sometimes and sometimes not. You have both sides. You have it where it is a business nowadays. You also have it where, again, we've taken it traditionally, but as a Aboriginal people in enslavement, doula wasn't our term. Doula is actually a Greek term that came into play, and that meant to come to mother the mother. In our paradigm, our traditional support of our reproductive health system and our maternal health system, our focus was that you had the midwife and you had what's called a birth assist. She was the birth assistant. She was the auntie, the grandmom, the sister, she was whoever else was present in the room. And we had our own traditions and our own teachings of how we supported a mother through labor and pregnancy, which included herbs, which included the use of also other practices and knowing what to do with our hands and positioning and so forth. But we worked together. So usually you saw the midwife and the doula working together. In today's time, the doula provides informational support. She provides emotional support to the family. She also provides the physical support in the time of labor. For the midwife, such as myself, who is skilled and trained, we're doing more of the clinical aspects. We're arriving at the time of a certain stage of labor, and we're monitoring, the baby's heart rate. We're monitoring the vitals of the mother as she's laboring. And then we are also the ones who are assisting in the deliverance of this baby. Whereas the doula does not do any of these clinical practices, okay? But again, we work hand in hand. So that is our primary difference. So here, what I'm showing you here is, like we said, we have to go back to really understand when we're talking about the outcomes that we're having today, we have to understand that our system to begin with around our wombs and our reproductive health was broken from the beginning. We were not intended to be free. That was not the thought. So over here, the one book that I have for you as a reference and just to highlight, The Price for Their Pound of Flesh, is a book that really highlights about how our wombs were a commodity, okay? How our brown bodies and everything and our babies was a commodity, because it was our children who fueled the economy of this land. And so you have to understand that our reproductive health system, maternal health system, was never provided for us. It was never meant for us to thrive as such. So these outcomes that we're having at this time these are not surprising, because the system we have is not supportive to us. So it's the understanding too that the midwives, okay, when the slave owner or the master was calling upon us, okay, we were able to not only help, so in that we were saving our lives, okay, because the way a woman was looked at is she was bought according to how many children she could produce a year. So she stayed in an example forever pregnant. There were some of us who were just, that was all we were there for. So to help our when you talk about gynecology and help with our existence, this is what the midwife did. She used her knowledge of herbs. She used her knowledge also of how not to get some of us pregnant. Okay, so the herb cotton bark was used to prevent pregnancies in other ways. So, in point being, she's very knowledgeable. She was a strong proponent in actually birthing not just our babies, but also the enslaved masters' babies, because that's what they need to do. So they would rent us out to other slave owners. for their own. And then, as far as us being wet nurses for breastfeeding, they utilized us. They utilized our breast milk for their babies. Okay, so all of that goes along with the midwife and her role, and the doula, who is the birth assistant. Okay, so we had an established maternal health system. We had an established reproduction health system. And then over here, where it says from midwives to medicine, it talks about and goes into the history of how that transition took place, how the transition of gynecology came forward, which you all know about the story of Sims and his experimentation, all of our bodies being experimented on, which again is no surprise to what's happening today. Again, our ovaries, our whole system was not meant to thrive and be this healthy place. It's unsafe. So here we have the results that we do. And so where you saw Marion Sims in New York, his statue coming down, and and them taking away the aspects of him being the doctor of gynecology and such. But really understanding that it was us, it was the midwives who started our first gynecological system and our birthing system. So you can move on from there. 2 books I definitely suggest for great reading. So from there is the Shepherd-Towner's Act. And this was the start to the finishing and the annihilation of all of the Black and granny midwives. Grand midwives is what we're called, which was started in 1921 is where it was enacted, okay? Before there was a total of 4,000 to 5,000 Black or granny midwives from the South, even coming on up here to the North. So like you were saying, Dr. Edwina, this isn't a new concept, okay? It is a forgotten concept, but this isn't new. So the practice and the care of the midwives, basically, this is where herein came coming into hospitals, where hospitals was looked at as the more modernized way to go, the more modernized way to happen. And so a mentality or a mindset shifted. And to make this reform happen, they had to somehow show that the midwife was incompetent or that there was something wrong with her. So they began to show us as being unclean, saying that our practices were resulting in high levels of infant and maternal mortality, when in actuality, the reasonings was the social determinants that you were speaking about, Shawn. Social determinants of our living and conditions affected the high infant mortality rates, but that is what they coined it as. And so then they found a way to wipe us out. They also found a way to regulate us, which is what is in practice or in place today. And the regulations basically required us to be registered with the health department. We had to prove our cleanliness. We had to use the tools that they required, which now took away our historical healing methods, our healing traditions. It actually wiped out our practices that we brought and that we were using in our medicine. And so that this also then required us to be in their training sessions and in their classes. And so this is what came forth as to the development of nurse midwives or nurse practitioners in this way. But it was white led. So in a sense, here we were integrating, which on one hand, yes, it was good that the benefit was now us coming into the hospitals, but what the goal was, or what the whole focus was not about our, upward movement in our health as a Black and brown people. It was, again, they saw and they knew the midwives basically had the effect on the community and were mainly the main source. And so they needed to do away with us. Go on. And then, so from here, I just wanted to tell you all, in my journey of being this, I have been in this now for going on 6 or 7 years as a Black midwife, a traditional community-based midwife. My practice of Ahava Birth and Beyond, and my, nonprofit Ahava House and Institute, like we said, I have been here for a number of years providing this care as a doula for 20, and then as the last 6 as a midwife. I am the first and was the first Black doula-led practice here in the state of New Jersey, going back to 1999. And I primarily was working with Deborah Bunyaro from DONA. Some of y'all are very familiar with DONA at this point. And I've also, I am the first Black midwife here for the city of Trenton and central New Jersey. Our other midwives who were here have moved out of the state because our state gives the worst regulations and support to home birth. So what I represent is our past. What I represent is our legacy and our history. There are many who have a thought about, well, home birth being safe or not. And what I have to say to that is that birth period in general, it doesn't matter where you are. It doesn't matter if you're home. It doesn't matter if you're in the hospital. Birth can take a turn at any point in time. But when it is someone who is considered a low risk family, a low risk pregnancy, there is no reason why this person couldn't be supported to be able to birth at home. Our training, and I think the misconception that happens, and like Dr. Bonaparte was saying in his reference, midwives are not seen as the truly skilled and truly important resource that we are in our community. We are looked down at, starting back from that Shepherd-Towner's Act, which, mind you, is going to be the centennial coming up in November, 100 years where this act wiped us out. Whereas now you're going to start to see more and more of us are coming back. More and more of our tradition is coming back. And especially in this time right now of COVID, because just as you're saying, no one wants to come into the institution. No one wants to expose themselves. They'd rather have care within the home. What I would hope is that those of us who are healthcare providers, who know and are here for our community, my hope is to be able to collaborate so that we can actually have a stronger type of care to offer to our families, and really see that we're actually trained as emergency preparedness responders for maternal health and for birth. So we're here, but we're not being utilized. I, under supervision, because you do have to have your license here in New Jersey. So I work along with licensed midwives until I sit for my license in November. But I typically service at least 6 families a month and we've had successful outreach, very little transport, very successful breastfeeding rates. So there is research out there that shows about our statistics and our outcomes and the value of using us. But I think that until we really realize that this was not a system ever intended for our wombs, it was never intended for our Black men as far as their reproduction either, because our Black men the same, they were used as bucks, they were used just for that, to produce so the land could be worked. So what we're seeing is that reflection, and that's not going to change just by having these gatherings of, well, let's have a cultural workshop among, all of our colleagues. It goes deeper than that. This is a spirit. The racism and such that's within the system, it started back when the Constitution was signed, and we were not at the table for that. That's not what we were a part of. So the only way we're going to be able to address this is coming back you know, and I feel this is why God pushes me, and then my purpose, and this is my passion, has been so for so long. And as a minister, is realizing that his institution of the midwife, she's a solution. She's always been the solution and the answer. And I feel that going forward, working with us and our work together is vital to change, to really change and really be there with our families, and to have the access that some of you all are speaking about that's limited. We have the access because we're trusted in the community. They see our faces. We go into the homes. And so, yeah, so that's what I want to share. And also that I myself too am a 4 times over home birther. And some of my statistics, unfortunately, are some of the first home births for a Black family here in Trenton. And that's horrible. That's a lack of access. That's a lack of access. And when sisters or brothers find out, when families find out that, hey, this could be my option, you know, they're surprised that they never knew that this was available to them. And when you talk about cost effectiveness as well, you know, we save money. We save money. And I think that is too why we're not supported, because we also are taking money from the system. We're also taking money from the insurance companies and such that have whatever set up, you know, for with hospitals and with care. But yet we provide the best care because we're people oriented. We are among our own people to know this, to know our culture, know our traditions, to know how we should be treated and supported. So those are the things that I want to share.
Thank you
Thank you.
so much, Elena, for sharing your experience as both a doula and a midwife. You have opened our eyes and enlightened us to the difference between the two and the history of midwifery as it points back to the biblical text. And, you know, most of us on the panel are ministers of the gospel, so our ears open up a little more when we see and read scripture. So we have about 10 minutes left in our conversation or our time together today. And we're going to open this up to the audience for question and answers. And we have a number of questions that have appeared in the chat. And we're going to go back to them. And I appreciate everyone for asking their questions. The first question is for Dr. Bonaparte and Dr. Verner. And the first question is for Dr. Bonaparte. Do we need more clinical research that explicitly includes people of color at sufficient numbers to understand population differences in response to disease and to medical treatment? And I can read that again to you if you need me to.
No, I'm good with
Okay.
that. And thank you so much. I appreciate it. And thanks for the opportunity. That is always helpful. It is helpful. But I think, you know, overall, you know, there is some differences, but most of our DNA and our makeup is pretty much the same. I think our environments are same. Are different rather. And I think that's the key. We need to understand. One of the things that I've noted and speak quite a bit on is health literacy. People, you know, the medical field, how we communicate with people of color. It means different things to us, and they, when we speak to them, it means different things to them. So understanding, and not just from an African American perspective, but also from a spiritual and religious perspective as well, make a huge difference. So I think yes, it is good, but I think we need to look at diversity as well, and I think that's one of the key things. The numbers is important, but as you know, because of past history, we need to figure out a way, and maybe what can be done, I think maybe a better way to do it is to empower people of color where they can trust. When I see people that look like me, talk like me, understand me, it makes it so much easier. And I think, you know, maybe funding need to go to Black-owned, Black-operated research programs, or create an avenue where we can get engaged in the research business and enroll people, you know, and be more I would say, compassionate and all of that, and transparent in sharing that information with people of color. That would be my recommendation.
Thank you. Dr. Verner, this question, can you speak to the issue that by the time people are signed up and approved for Medicaid, that they are often well into their illness or their pregnancy? How does this impact health outcomes?
First, you want to get people involved in healthcare before their illness gets to a point where they're going to have a bad outcome. So yes, again, there's a whole political thing behind this. Even under the best of circumstances, it's a maze that you have to, negotiate through to get insurance. It's not easy, especially if English is not your first language. So yes, it's an ongoing issue. One of the things that we have at FQHCs is somebody who can help you get enrolled in health insurance. But yes, it needs to be done as quickly as possible, because the outcome, of course, will be different if you wait until your illness is advanced. So it needs to be done soon. There are places where you can go to get help, because it is very difficult to negotiate the system.
Thank you. This question is for Elena. Some theologians view Jesus as a shaman and a healer. There's a story about him using, spit and dirt to create mud and wipe across somebody's eyes, a blind man's eyes, and he is healed. Being that you're from Georgia, how have we as Black folks used the earth to heal?
Okay, well, what's our legacy is the use of our herbs. God, presented the earth to us. And even that, you said, dirt in itself, but that holds minerals. It holds all of these things. So that was our medicine at first. And so there are specific herbs that we utilize holistically on a daily basis, such as nettles, which is a blood purifier, and iron. And so these are some of the aspects. And nutrition. Nutrition was very strong, a key that we used historically to help us to heal. And in the same way today, the way that the food is grown, or where, obviously, though, we have to admit that our food sources aren't the best, and that's a whole nother topic. But that is the way that we approach healing, and on a spiritual basis. Yes, our herbs and our nutrition.
Thank you. And this question can be for, whoever, has the knowledge for this. So New Jersey legislature recently passed a bid text on hospitals and SEDs, which need to be watched because no one knows what the outcome would be for communities of colors. When hospitals were closed, SEDs, and I'm not really sure what that means, were placed in some communities, and they serve as a funnel for the insured and to be steered to the controlling hospitals. This SED tax amounts to over $100,000 to those SEDs. Will they survive? Only time will tell. I guess that's more of a comment. So a question for Elena: what changes in insurance policies might be needed to make payment for doulas and midwives more possible?
The medical insurances, first and foremost, well, first, it has to be seen that we are relevant, which is just starting. The governor just passed legislation about supporting us now in New Jersey to be working in birth centers or birthing centers, CPMs, Certified Professional Midwives. So there are some insurances that do cover our care, but to get for more universal coverage, there's going to have to be more legislation that is addressed, and more politically, to show our importance and our relevance, but also to show that the consumers want us. And so that is what's going to have to come forward more. But right now, we have the worst rate ever in the overall world economic. We're only reimbursed $300 here in the state of New Jersey. New Jersey has the worst rate overall. So $300 for prenatal care all the way down to labor and postpartum care that we provide. So obviously, you know that we are not in this for the money, but definitely for the support and change of lives for Black families.
Thank you. You also had another question from Baba, but he said you answered his question. So thank you. So this question is for the whole panel. And I know we talked largely about, health as it relates to, the binary, male and female. For those who don't identify with male and female, and this is a tough question because a lot of, folks who identify as Christian or who are ministers try to steer away from this question. What does health look like in New Jersey for folks outside of the male-female binary, or what does transgender health look like? And Dr. Verner, I know you work with children, and I'm sure some of those children are,
Yes.
moving towards, who am I? So what does, health look like for those who are LGBTQ or those who are transitioning in New Jersey?
Well, I wish I had a good answer for you. It's something that we are working our way through. You're right, much of this begins in adolescence. So we see adolescents who are, I don't think I have any patients who are transitioning, but who definitely assign themselves differently or non-binary or whatever. And it's a work in process. I wish I could say we have a good foundation to deal with. We don't. We need to work more to get a group of people together, the behavioral health people, to deal with the issues, not just with the adolescent in my case, but of course the families. It's tremendous difficulty in parents dealing with them, so we have to deal with them, and with the medical issues of the individual involved. So it's a work in progress. I'm feeling my way because it's a new problem for me in pediatrics, and I look for support wherever I can get it, both the behavioral health and the medical support. But do we have an organized, concerted way to deal with it right now? Certainly in adolescence, I don't see it yet, but there are places that I'm using people that I'm working with as it becomes more of an issue, so that hopefully we can review this on a more, concerted effort.
Excuse me, I would like to add in this too, as out of hospital midwives, we're also specially trained to work with the LGBTQ community, meaning that cultural and biases that are experienced and such, we are trained to deal with transgender and how that would be for pregnancy going forward. Someone who hasn't gone all the way forward with the change, and what does that mean hormonally and such. What we are able to do or like to do is collaborative care, which is because they need a special level of care. Is home birth out of the option for them? No, but we would like and do like to collaborate with another healthcare provider because of monitoring, specific monitoring that needs to take place. But when it comes to chest feeding and birth, we are able to support everyone for their birth choices or options.
Thank you, Dr. Verner, Dr. Bonaparte, and Ms. Broach. Our time together today has been both enlightening and refreshing. Thank you so much for your experience, your expertise, and the information that you have poured into us on today. There was a question raised of how do you become a part of the Sankofa Collective, which was asked. You can text join Sankofa to 22828, and it will put you on the mailing list. So again, I want to thank all of our panelists, thank all of those who joined us for this lovely conversation today, and thank the Sankofa Collaborative for these last 3 weeks of conversation around healthcare access as a civil right. I would like to turn this back over to Michelle, if she has, or Dr. Epps or Dr. Stevens if they have any final words.
Well, thank you, Reverend Torres. And to all of our panelists for providing us once again with wonderful information presented in a very clear and concise way that I'm sure is much appreciated by all who are viewing. Once again, you can find, this was recorded and it will be on our website. And I'm also told that we have a new YouTube channel and you can also find it there. Thanks again to our panelists. Please consult our website often. Weekly, we post new resources for those of you who are interested in this subject and others that are concerning the African American community. I know that every week I find something interesting there, and I'm sure that you will too. Once again, thank you to our audience, but a most hearty and loving, warm thank you to our participants.
Thank you.
Mhm.
Bye, guys.
Bye.
Bye, everybody. Thank you so much.
Thank you so much.
Thank you.
Bye.
Bye-bye.
Thank you.